Hi class, we're going to do one more video for chapter 9. It is a long and complicated chapter, and then we will cover the rest in class, where we will also be going over the exam and the impact of the exam. So I'm recording this just after having with you gone through this kind of mess that the first exam was. So again, I apologize for that, and we will have grace for each other and we will work it out. So we were talking about speech disorders in special populations, and the next one I want to cover is those disorders. We're going to call this phonological disorders in special populations, and we're going to list a number of them. So they're all going to fall under this heading of special populations. The first one is in those children, since we're talking about speech disorders in children, but this obviously carries over into adulthood. So those children with Down syndrome. So the medical term for Down syndrome is trisomy 21. It is a congenital developmental disability, meaning present, congenital meaning present at the time of birth. And some of the common characteristics of Down syndrome. The first one is the most prevalent, the one that we all think about, and it is the intellectual disability that comes along with Down syndrome. And it can go, it goes in a range from very mild to more profound kind of intellectual disability. Now, I'm going to explain the term that we no longer use for that, the term mental retardation. The term mental retardation is actually a much more descriptive term of this intellectual disability. And because if you take it apart, the word mental referring to those cognitive processes, and then the term retardation simply means developing slowly. So for those of you who are musicians, you know it's the same root word as the Latin word retard, which means to go slowly, when you slow down when you're singing or playing a piece of music. So mental retardation is actually a very descriptive term. We don't use it anymore. It's not considered politically correct or appropriate, and mostly because it has been co-opted as a term of derision. And so obviously we're not going to stick with that term that has been co-opted to be an insult. So you'll see, though, the term in older literature, and then the term we use most typically today is intellectual disability, intellectual impairment, or developmental disability, but most frequently you'll hear intellectual disability. Some other common characteristics of Down syndrome: they tend to be small in stature. Those with Down syndrome tend to be so shorter than the genetic makeup of their family might otherwise suggest for them. They often have heart defects that come along with the Down syndrome. They can and often have hearing loss also that comes along with it. Not always, but frequently enough that it is considered a common characteristic. They have a small oral cavity, and this is sometimes mistakenly described as that they have a large tongue, and they don't. The size of their tongue is really typical for a person their size. However, the oral cavity is very small, and because of that, the tongue appears larger. It's usually carried forward in the mouth simply to make breathing easier, but that does also have an impact on their speech ability. And then they will have the language delays that are going to go along with the entire intellectual disability, or that slowing of the development of cognitive processes. Their typical speech issues is that they will have a somewhat limited inventory of phonemes. If you've ever listened to someone, an adult with Down syndrome, who has had really good education and good therapies, you will hear that there are still some speech errors in their speech. But as children, that is a much more profound issue and requires a lot of therapy. They will have delayed development of those phonological representations of sounds, And that just comes along for the ride with the delayed development of all cognitive processes for them. They often have poor phonological memory, which then also contributes to that slower development of those phonological skills. They're at, as I said, increased risk for hearing loss and heart disease, but also increased risk for articulation disorders due to the dental and oral size differences and different anomalies in development. Down syndrome is caused by a chromosomal abnormality, often associated with maternal age, meaning we often associate Down syndrome with mothers who are older during their pregnancy. But it's not a perfect association. It is more as a woman ages, she is more likely to give birth to a child with Down syndrome. But the opposite is not true. I have two acquaintances who their first child that they had when they were in their early 20s had Down syndrome. And then they went on, and subsequent children did not have Down syndrome. By the way, the older a father is, the more likely that a child is born with Down syndrome as well. Early intervention, you can imagine, is of huge significance for these kids. So the second special population that we'll talk about is hearing loss. Now, I know we already talked about the kids with chronic otitis media or otitis media with effusion. That's a really specific kind of hearing loss because of that buildup of fluid in the ears and the chronic sickness of it, the fact that these children are sick with an infection over and over and over again. That's a very specific kind of hearing loss. So this is a much more general category. This covers hearing loss that is either a permanent loss or some transient hearing loss for some reason. But if that hearing loss is happening during the ages when speech and language are developing, it will have some impact on their auditory intake. So I explained the term auditory deprivation. So you can imagine if this is a one-time short-term hearing loss, a child has one ear infection or two ear infections, and they don't have that effusion with them. It's still like having cotton in your ears at that time, but if it's if it lasts a week or two and it's treated, it's probably not going to have a big impact on the development of speech and language. However, if this is a persistent hearing loss, a hearing loss that the child is born with and is going to be persistent, the greater and the more permanent the loss, the greater the impact on speech and language development and then subsequently speech production. Some causes and risk factors for hearing loss. We're going to look at three different kinds. The first are prenatal causes. These are things that result in hearing loss in the developing fetus, so during the pregnancy. Now, these can be from chromosomal abnormalities. We just said Down syndrome can have hearing loss that comes along with it. There are other chromosomal abnormalities that can result in hearing loss. It can be, by the way, genetic. Hearing loss we know that they can even identify a gene for hearing loss that will then run through families. But it can also be caused prenatally by things like maternal ingestion of toxins and medications. So either the use of legal prescription drugs or illicit drugs, or some toxin that's entered the system, some poisoning that's entered the system. Many of our prescription drugs are what we call ototoxic. They're toxic to the ears, both of the mother who would be taking them or the developing fetus who she's carrying. But remember, and I'll repeat this often during the semester for other reasons, we save lives before we worry about things like this drug might impact the child's hearing. So, for example, the mycins, erythromycin, streptomycin, those are ototoxic drugs. Aspirin is an ototoxic drug if it's taken in huge quantities. Some perinatal causes. So these are things that might happen at the time of birth. If there's any kind of trauma at the time of birth, such as the same kind of trauma that might cause something like cerebral palsy, could result in hearing loss. Or anoxia, lack of oxygen, anoxia, anoxia, at the time of birth can result in hearing loss. Doesn't always, but it can. And then postnatal causes, so things that come after the child is already born. Things like bacterial infections, like meningitis, can result in hearing loss. Any kind of head trauma, or either accidental or intentional, can cause some hearing loss. And exposure to loud noise. Little children aren't sheltered from the same kind of things like explosions that could cause traumatic hearing loss. And then again, medications. If a child had some disease process that required, for example, a use of one of the mycins in large doses, it could result in some hearing loss. There's a list we're going to go through of 7 signs of potential hearing loss. Some of them sound like pretty obvious, but others are they're a little more vague, so I want to go through them. The first one is if a child is reporting any ear pain or a feeling of fullness in their ears. They need to go to a doctor. A doctor needs to look at it. It may be something that's indicating there's something that might be causing some hearing loss. Anytime there's discharge or bleeding from the ears. So, for example, in concussion, it's one of the signs of concussion is that there's some bleeding from the ears. Bleeding from the ears could be because of a ruptured eardrum. That's going to cause some temporary hearing loss. It could also be from something more significant. So, those are things that we need to have examined by a doctor. Anytime a child is reporting a sudden or a progression of hearing loss, they need to be seen by a doctor or audiologist. The fourth one is that you are noticing as a parent, or even the child is reporting unequal hearing in both ears. So you have this maybe newborn or infant, and you notice that when you stand on one side of the room and talk with them, they turn towards you, but when you're on this side, they don't. That's a sign that they need to be seen by an audiologist or a doctor first, and then an audiologist. Any time that a child, in this case, many of these apply to adults as well, but anytime we're reporting there's some hearing loss after an injury or a loud sound. Now, I'm sure you've all been in a really loud environment, like you went to a high school football game and everybody's screaming and cheering, or you were in a club and there was a loud music playing, or you went to a concert with loud music, and when you come out to the parking lot, you notice that the sounds are all a little muffled. Okay, we'll get to what that's called when we get to the chapters on hearing loss, but you notice that it resolves within a few minutes. It's gone. But sometimes it doesn't resolve. So when someone is saying, wow, I just don't think I can hear as well as I was before, or in the case of a child, if they're responding differently to loud sounds than they did previously, that's a big sign that we need to look for hearing loss. This one is sort of diagnostic in nature in terms of our job, but if a parent is reporting to us slow speech and language development, one of the things we always have to rule out is hearing loss. So you'll hear me say this throughout the semester now, we never, ever, ever do an assessment of anybody's speech and language without first doing hearing assessment to make sure hearing is not what the problem is. And then the last one is any kind of balance disturbance. We know that it's all the same structure in the inner ear. So when someone's having a balance disturbance, it is possible that there's also a come-along hearing loss with that. The next special population that we're going to talk about is those with cleft palate. Cleft palate is also a congenital issue, meaning it was present at the time of birth, present in the developing fetus. So it's a congenital malformation of the palate, the roof of the mouth, and it affects 1 in about 700 newborns. That's not a terribly small amount. Cleft palate can be unilateral, meaning on one side. It can be bilateral, and it can involve the lip on one or both sides. Typically, surgery is done pretty quickly, during the first year of life, to close the palate. Now, that surgery is not done for speech purposes. That surgery is done for safe feeding and swallowing purposes. However, even after that first surgery is done, there will be remaining physical issues, such as limited use of the muscles, of the lips, for example, or the soft palate. There may be missing or misaligned teeth that came along with this cleft palate syndrome. Additional surgeries will be ongoing for this child, some of them to correct cosmetic issues, others to provide additional function. These kids are going to come along with speech difficulties. They'll have a variety of speech difficulties depending on unilateral, bilateral, how well the surgery was able to restore any function that was missing, how the teeth were impacted. There's just all kinds of variety of speech issues. But the overriding issues that will come with cleft palate are distortions of sound because of insufficient ability of the velum to close off to the pharyngeal wall so that we can have oral and nasal division of sounds. So if the velum can't close off, we cannot build up oral air pressure for the oral resonating sounds. And if that's the case, we're going to have a lot of nasality in the voice, or we're going to even have nasal emission during production of sound. Now, I'm going to show you nasal emission, but I don't know how well it's going to work over video, so hang in with me. For a child who may be trying to say the word sun, we have to have buildup of air pressure for that s to come out, right? If air pressure cannot be built up in the oral cavity, what we're going to hear instead is hun, hun, and all of the sound is going to come up through the nasal cavity. So we're going to have nasal emission, hypernasal sounding speech. And then we also will just have consonant distortions because of difficulty with placement of the articulators. If we're missing teeth in the top, or if there's just too big of a gap, if the lip can't close all the way down. It's not uncommon for people who've had, especially from my generation, cosmetic surgery has improved so much since then, but people from my generation or older, that upper lip just is very short. So their M and N sounds are often made, or excuse me, their M and P and B sounds, the bilabial sounds, are often made using the teeth and the bottom lip. So maybe we would say Mary, pop, bag, and we would use the teeth and the lips to make that sound as close to a bilabial as possible. So those misarticulations are also coming along for the ride. Some of the causes and risk factors with cleft palate. Typical fusion of the palate happens between the 8th and the 12th week of gestation, so during the 2nd and 3rd month of pregnancy. There are 400 different syndromes that can have cleft palate as part of the symptom mix that comes with those syndromes. The book lists 3 of those syndromes for you. I am not going to ask you to remember the names of any of those syndromes. Mostly I just want you familiar with what are the common speech issues that are going to come along with cleft palate. And then the 5th special population is those with developmental psychosocial involvement. And this is an area that is not very well understood, that crosses the professional borders between our scope of practice as speech pathologists and perhaps a mental health social scope of practice. This may account, though, for 7 to 12% of kids who present with speech errors to us. So it's a pretty big population of kids. And it's due to psychological factors, things related to temperament or personality. These kids may have some withdrawal or avoidance behaviors, but this is not the same thing as the child who is selectively mute. This is children who have speech pattern errors or speech production errors that are part of that temperament, that withdrawal issue. The best description I can give you of this is these kids may use a very infantile kind of speech pattern, both in their voice, in their prosody, and in their articulation of sounds that's unrelated to their ability to actually produce those sounds when you ask them to imitate you producing them. They have that ability, but they, for whatever reason, probably not a super conscious choice, are choosing to use a much more infantile speech production. As I said, it's not real well understood. I've really only had a couple of kids on my caseloads all these years that, I'm sorry, I have to log back in. Bear with me. I've only had a couple of kids all these years that I've been in the public schools that present with this, or that I suspect have presented with this. And it was helpful to have school counseling or independent mental health counseling along for the ride with the treatment for those kids. So we're going to move now to assessment of phonological disorders. And I'm going to try and get through this whole assessment piece, but I think we're already up to about 20 minutes, so I may cut it off in the middle and we'll finish it in class. Assessment for phonological disorders or for articulation-related disorders, typically a referral is made to us either by a parent, a pediatrician, or an early childhood educator, a preschool teacher. Sometimes that referral doesn't happen until a child hits school age, and that's kind of unfortunate. We wish they would come earlier. For a child under the age of 2, the signs of a possible delay or the red flags would include suspected hearing loss, chronic ear infection, or some known physical impairment, either a mental or cognitive impairment or an actual physical impairment. So the cleft palate, cerebral palsy. Those kind of kids, they get services usually from infancy on because the pediatrician is referring out to, for example, county services that are available for children with developmental disabilities, or they're referring them to private health insurance covered services. We also have a known risk factor that is limited exposure to speech and language. For example, I had 3 children from one family. I think there were 5 altogether. The parents of these kids were both deaf, and they used sign language to communicate. So that's a known risk factor. The children all had normal hearing, but it is a known risk factor in the family then for them to have delays in speech and language development simply because they're not getting the auditory stimulation. Now, none of them had language development problems. This family did a fabulous job with these kids, but I did assess 3 of them. One of them had some speech sound production errors unrelated to his parents' speech. But it is a case of a known risk factor because of limited exposure. That can also happen in other situations. And if you want to know more about that, ask me another time because we don't have time to talk about it right now. Some specific vocal or verbal behaviors, now 2 years and under, that are warning signs. Delay in vocal play. So this is a child who's really very quiet as a small infant. They don't make a lot of noise. They don't play with their voice. They don't play with their sounds. They have a delay in the onset of babbling, delay in the onset of first word acquisition and 2-word combinations. So you're seeing the pattern here. Everything is delayed. This is a huge red flag that this child's going to have speech disorders. A child that presents with a limited repertoire of speech sounds. So if by age 2 you're not hearing them begin to have some variety in the sounds they're using, if they're still just using ma, 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 by age 2 we should be starting to hear a lot more phonemes from this child. So that's a red flag. Also, a lack of intelligibility, but this time with a familiar audience. By age 2 or age 2 to 3, we expect that many kids will still be difficult to understand to an unfamiliar listener. But if within their family, the immediate family in the home with them, they're still not understanding them, big red flag for speech development issues, speech disorders. And then the child that relies on nonverbal communication to get their needs met. And we hear this because remember I do preschool assessment. We hear this all the time. We ask, how do they let you know that they want something else to eat, or that they want a drink, or they need to use the bathroom, or they can't reach a toy? And the parent says, they pull me to them, or they climb, or they point and cry. This is a child using nonverbal means to get their needs met. They're not even attempting speech. We know that early intervention is certainly most optimal for complete success because we know that it is between the ages of 12 and 18 months that children truly begin to communicate. They begin to use language to communicate. By the time they turn 2, they should be more intelligible. They should be intelligible about 50% of the time. And by the time they turn 3, they should be